I knew it was going to be painful, but I actually didn't have a clue how painful it was going to be.
I recommend it to anyone? From a pain perspective, no. Right? I would definitely say if you can put up with what you've got, put up with it.
When I first decided that I needed to get the replacement, I was 30. So I saw my GP and he referred me to a surgeon. And I went and saw the surgeon. He said, yes, I did need a replacement, but I was too young.
Hi and welcome to Tonic, I'm Norman Swan. Today's programme is about a very common problem. It's knee pain due to osteoarthritis. It's much misunderstood and, as you'll discover, often inappropriately diagnosed and treated, particularly with surgery.
Osteoarthritis is a very chronic condition. So patients with osteoarthritis commonly will have osteoarthritis for a long time before they even get any symptoms. Osteoarthritis is a spectrum of mild to moderate to severe. You see that shiny, smooth ball on the joint? That's the cartilage which allows the joint to move without friction. When that wears down or degenerates and becomes less smooth, it can cause stiffness and pain in the knee, and this is osteoarthritis. And what happens later is there are secondary changes in the knee, such as spurs can form, little outgrowths of bone. General process of degeneration extends beyond that, and even the menisci can become degenerative. They're made of cartilage, so just like we get wrinkles, we can also get degeneration in the menisci and in the cartilage inside the knee.
I work as a bus aide on a special needs bus. So I have to climb up 4 large steps to get onto the bus, and I also have to wheel the chairs in off the hoist at the back of the bus and then bend down to lock in the wheelchairs. That had got to a stage where prior to the knee replacements, that it was just a struggle. I could get down, but then it was trying to get back up. And of course my kids were still active and doing things and I couldn't participate with them. And the pain was continuous and nights I couldn't sleep.
In osteoarthritis, often the main symptom that concerns people is pain. And controlling that pain is usually possible with a range of medications ranging from paracetamol, which is a fairly weak painkiller, and then moving on to things like anti-inflammatories, which are a bit stronger, a little bit more effective, but with more side effects. And then at the other end of the spectrum, where pain is not well controlled, then sometimes the opiate medications, the narcotic type medications can be introduced, but with reservation because they have their own sets of problems.
Evidence is increasing that weight loss can play as important a role in delaying or reducing the need for total knee replacement, and it might be easier than you think. Most studies show that a considerable benefit can be obtained when you lose just 10 or 15% of your body weight. For most people, that means less than 10 kilograms.
For many patients, treatment isn't necessary. Many patients are concerned about the findings that they come to me with on their x-rays or on their MRI scans. They're concerned about having tears in the cartilage or loose bodies. They're worried about the future, about whether this is going to rapidly progress, whether they're going to be able to continue with their daily activities. And many of them are currently coping very well. They can still walk the dog and socialise, and they don't need walking aids. Osteoarthritis is commonly associated with fluctuating knee pain, and it'll be bad one day and it'll be okay for a week afterwards. And I would say a large proportion of the patients I see are happy to have no treatment and to merely be reassured and to continue coping with the condition that they have.
I went to see an orthopaedic surgeon and he performed an arthroscopy and told me exactly what I thought was wrong. And he said, come and see me when you're 65 and I'll put a knee in.
So osteoarthritis can be diagnosed from the history of symptoms that the patient gives you, and they'll often describe pain in the knee and also stiffness, particularly stiffness when they start up. So if they've been sitting down for a long time, they might say it takes them a few steps to get the knee oiled. And the pain is often very well localised to what we call the joint line, and that's the gap between the top and the bottom bones of the knee. And so if you see a patient who has a long history of knee pain that comes and goes, and they have bowing of their knees, and they can have spurs that you can feel with your fingers when you examine them, that's pretty typically osteoarthritis.
You can diagnose it very easily with a plain X-ray with weight-bearing views, so an X-ray with people standing up, so you can see the narrowing of the joint, and it's very clear on an X-ray.
Even though osteoarthritis can most appropriately be diagnosed on an X-ray, many patients aren't getting X-rays. Instead, they're receiving an MRI, a much more expensive image that doesn't add anything. At the end of 2013, GPs were given the right to order an MRI for only 2 conditions: a fully locked knee or a suspected ruptured anterior cruciate ligament, and order them they did.
In 2014 alone, there were over 133,000 MRIs ordered just by general practitioners, and that cost the government $50.1 million.
The MRI scan, apart from being expensive, does show a lot. And the MRI scan will often show tears in the menisci, degeneration and wearing of the cartilage, and sometimes loose pieces of cartilage, and these can be misinterpreted. Often the patients get quite alarmed when they see that they have loose bodies in the knee, which is actually quite a very common finding, or if they have a torn meniscus.
When referring patients for MRIs, the GP should be looking at the evidence which is available to them through clinical guidelines provided by the College of General Practitioners.